The best learning time is Q&A.
Hello?
Okay.
For the organ-specific cells, how
Yes.
many treatments? Is it at one time every 6 months? How do you do that?
Now, when we say the cells, the stem cells, let's say for diabetic patient, once a year is good enough. Okay, when you say autistic children is different. You may have to do it every 6 months. Okay, diabetic patient is wonderful. When you talk about Alzheimer's and Parkinson, it depends on the condition of the patient. You know, normally we Parkinson and Alzheimer's may be 6 months for the first 2 times minimum. Then we can put it every month. Diabetic patient, no problem.
For the kidney failure?
Kidney failure, it depends on the condition. I would say every 6 to 9 months.
Okay.
Okay. But the important thing is, first treatment itself, after 4 months, you see the results. Because if you don't see the result, the patient will not come back.
Right.
And he may say something bad about you. That is the problem too. He will say something bad and it circulate around. So that's why we also have to be very careful. Can we treat or we can't treat? Again, kidney patient with dialysis. I always insist the moment you have that dialysis in the morning, we treat you in the evening immediately. Or we treat you in the afternoon, immediately after the dialysis. Because during the dialysis, you clean up everything. So whatever proteins you want to put, apart from the kidney, you want to treat the diabetic, you try the islet cells, heart cells, brain cells, you will accept much better. Otherwise, the kidney will not accept a lot of things. The kidney will always accept the kidney. Okay, so the peptides of the kidney, no problem. Yeah.
Thank you.
So I've been using peptides, synthetic peptides. I practice in the US. So we use, CJC for Simorel and all this stuff.
Yes.
Today, that completely changed my, after listening to all your topics. So my question now is, is your product gonna supplement or replace the peptides that I've been using in my practice? I'm talking about the synthetic peptides that we use in the US.
You are saying that the peptides you're using, should we stop it or we replace with some new
Right.
ones?
So should I replace that with your product? Because we've been using like BPC, we've been using all these growth hormone
Okay, let's talk
peptides.
about BPC. Okay, there's a lot of heap about BPC recently, and a lot of them are using for Crohn's disease or for the gut. Okay, so we want to talk about the gut. What is the best supplements or best therapy for the gut? Of course, the gut itself. And what is inside the gut? Intestinal mucosa lining. It thins, that's why it ages, it thins. And that's the reason why you have this problem. Your gut starts to age at 55. So if you can give the intestinal mucosa lining, it's affecting all of us, including our parents. Okay? So if I give the heart, the stomach, and the intestinal mucosa of the stem cells, that would be the best. Next will be the cells. Next will be the peptides. And I would not say giving the exosomes will solve the intestinal mucosa of the gut specifically, because we are talking about same molecules. It has to be the gut. That would be the best. So someone was telling me along all the time in USA, why don't you use the BPC 157? But I say, for the gut, I'd rather do this. We did one on a billionaire in USA. He was using all this. He didn't see good results, and I gave him the stem cell and the intestinal mucosa lining. He's one of Hollywood's biggest producer. He has wonderful results. So you see, you give the right type, specific, right to the point. So I also is of the opinion, we are manufacturer of artificial peptides. We do artificial synthetic peptides. We also do the organic. So my opinion is, if I have to choose, I will always go with natural ones, organic peptides. And again, you notice some of the speakers say without chemical, without preservatives. So these are the cheapest. I mean the safest. You see, the safest. The good part about the peptide is affordable on anyone on the streets because it's cheap. If it costs a few $100s for a set of 10 peptides, it's affordable to all of you physicians. Okay? So it doesn't mean you buy 10, you must be for one patient. It can be for 3 patients. It depends. It can be even for 10 patients. So there are enough profit margin to be made. And there's enough, but first of all, please deliver. You don't deliver, they will never come back. Okay? So my opinion is use the natural one better than the synthetic one. And FDA USA is also clamping down on peptides. You know that, okay? So if I use organic one, I don't have problem. I don't have problem shipping all the peptides to USA every day. We ship to US every day. US is still our biggest market. Biggest. Can you imagine how attractive US is? I'm not talking about China, but to me at this moment, US is our biggest market. Yeah. So there's a lot of good things to look on. The laws in US is going down a bit. They're more relaxed. China has gone down a bit. Japanese is getting more liberal. Many parts of the world are opening. Many parts. If you go to Panama, you go to Bahamas, I'm asked to go to Antigua to meet the Prime Minister and the Health Minister. And this is funded by the Saudi rulers. They put 3 billion US into Antigua, set up a regenerative university. And I didn't know, I met up with the dean in UK. We are talking about, I didn't know who he is. And we are talking about, he said, one day he called me, he said, the health minister and prime minister want to talk to you. So I spoke to them a few times. Now I'm going there on August the 25th. August the 21st, you know. And before that, now I'm asked to go to Saudi Arabia because the lawyers there are asking me to go to Saudi Arabia because they are the funders, you see. So we are starting one of the longevity hub in Antigua, but we are also setting up one of the longevity wellness center or hub in Antigua, and that is allowed and approved by the government. So it doesn't bother me US government or Malaysian government don't approve this or that. Because if you don't approve, the clients will go somewhere else. It's always the case where the patient has a problem. If you don't allow him to treat in his country, obviously he will go to the next door country. You see the point? If Malaysia can't do it, they will go to Thailand. You know? Then if another country cannot allow it, they will go another country. No, everyone is afraid to die. Please understand. No one wants to die. So when they have a disease, they can't find solution, they will leave the country. It's like all the end-stage patients. You know where they go for cancer? All the end-stage patients in Asia or in Singapore, they will always go to China or they go to Taiwan or they go to Germany. And some go to Mayo Clinic in USA. It's always the case. Even end-stage means you don't want to die. You refuse to die. All of us are afraid to die. Okay? Even if you don't have money, the whole family will borrow the money and he will still go. You see the point here? So why don't we treat early? We treat early, we're going to save life. Prevention starts at the age of 30. I believe in that very much. Okay? So we have to start early because at the end of the day, you will end up making all the money, you become rich, and you are going to spend all the money to treat the disease. And you ended up without the money. You know? So it's important. So the greatest wealth in life is not your greatest wealth in life is actually your health. And the greatest thing in life is your happiness. Can you be happy even if you're a billionaire but you are sick? You will never be happy. So the greatest thing in life is your happiness, and that depends on the health. And that health depends on the extension of your lifespan with the extension of your health span. So longevity depends on health span, which depends on the cell span, the quality age of your cells. So do you need to become younger, all of us? Of course, we have to. Because you don't, you become older and you will die faster. And the organ will fail. So you have to play the delaying game all the time. You do a reversal and you delay the progression of aging. You go down like this, you pull up, you go constant, you start to fall. After some time, you pull up again. You keep pulling. So that is good enough for you to live to 120 years old. You just ask yourself after 30 years old. I mean, after 60 years old, 70 years old, even to go to the toilet to poo, your muscles will not be strong. The smooth muscle is coming down. Everything is coming down. What about the number of teeth in your gums? How many teeth you still have after 70? You see, everything is coming down. Can you do a regeneration of the teeth? I know scientists are going with a third set of teeth, but there's only in research. Can you now start to give bone to yourself? The answer is yes. Don't wait for the last minute. The bones start to go up 30. Dr. Simon is talking about the muscles. It starts at 32. Cartilage go down at 30. So these are the levels I think we have to do regeneration all the time. You can't afford the cells, the patient can't afford, then do the cells. Can't afford the cells, do the cells. Can't afford the cells, do the peptides. Okay? Exosome, you can blend along. Again, the exosomes were home to the area, but don't expect the exosome to do magic. Exosomes don't last 3 to 4 months. Okay, any other questions? You all have anything to compliment?
Hi. So just now Dr. Simon, we were talking about peptides with for is it not for Alzheimer's. So you
Yeah.
have Alzheimer 1, Alzheimer 2, and
Yeah.
everything. And then there's also CNS. So if I'm going to treat someone with stroke or maybe dementia post-stroke and this kind of thing, so which one should I choose? Should I choose CNS or Alzheimer 1 or 2, something like that? Yeah. Thank you.
So overall CNS, you can put the equal sign with the brain, and you are basically giving the peptides of the brain of all the areas. If you want to go more specific, like for Alzheimer's, for example, you better go with the Alzheimer's combo because it's got more specific, more specified parts of the brain extracts. And then if you want to go very specific, like you know that the person had a stroke, like let's say in the frontal lobe is the area which was affected. For most effective outcomes, you would use MO frontal lobe. So it depends on how much specific you want to be. If that condition involves certain parts of the brain, like Parkinson's disease, yeah, you know which parts of the brain are affected the most. You want to address specifically those parts, then you are choosing MO Parkinson's disease combination. Like all MO combos, these are just specific tissues in combination. So if you want to address a few tissues, you would try the combo. If you want to address all the tissues of the brain, you take just CNS or MO brain, which is the same. If you want to address some specific part, like in some lobe, you're taking MO of that lobe. Yes. Even can combine in one syringe
You
because
can put them all into one syringe because remember, all the MO can be combined, but don't combine the MO with the NOP. They're different, okay? The good part of the NOP is you can put sublingual because some people don't like jabs, you know, so you can do it sublingual. But you want to compare the NOP with the MO is better, stronger, okay? So the NOP recently we move up to triple strength, so they are stronger, you know. On our side, we try as much to give the best quality. Of course, that means to say we want to increase the dosage. But sometimes in manufacturing, there's a limit, you know. There's a limit in how much you can go in certain way of manufacturing and processes. Otherwise, it may be unstable. So when we talk about stroke patient or Parkinson or Alzheimer's, if someone will come to me, I would say you need the stem cells, the 6-star. Because we have to repair target. Stroke patient, the brain cells is dying every second, every now and then. So the earlier we treat is better, okay? So we must know which part from the MRI, from the neurologist report, we target that part, but again, Simon said the whole brain, yes. The whole brain will be affected, so you give the CNS, which is making up even of the spinal cord. Okay, and stroke patient have problem with the nerves, so spinal cord provide the nerves too. So you give the whole brain, but you target again which part of the brain. Like he say, if it's a frontal lobe, then I give a lot of dosage of frontal lobe. We can even give a quad dose. That means 4 times the strength of the frontal lobe. So this is how we play along. So we give the stem cells, and 4 months later, we ask them to do a comparison. And we're very confident they will see the result. And then they continue with the peptides because we don't want to see the patient all the time. He see us all the time means he pay us more money. Of course, we are happy, but that's not the way to treat the patient. He may not have the money, you know. So we always say you come back, you know. Once you observe from the 4 months, we decide when we need to do the next treatment. Okay, for stroke patient or Parkinson, Alzheimer, if there is an old patient, we may have to do it 2 times a year or 9 months. It depends on the condition. But for a normal patient, you know, once a year, like diabetic patient, once a year, we can keep it under control very well. Okay, yeah.
There is a Zoom question which says, I suppose Dr. Margarita is not here and we will email this question to her to handle. Either ways, I'll read the question out. Probably Dr. Shishkina or Dr. Klokol can attend to it. How about gouty arthritis? What can you recommend for stem cell therapy organs? Question number 1 from Karen Adapon Sajo, doctor. And the second question, which is Ops and Gynae. Can a menopause lady regain menses after starting stem cell therapy? Because I had a patient already, amenorrhea for 6 months. 56 years old lady, suddenly, after 2 months on MF3, she has seen menstruation. Anyone?
That is a good news. That means she's reversal. Why not? You know, I always tell a woman, you stop your menses means you age 30% faster. There's a hormonal disruption. Everything is drying up and changing. So you're reversing means you have the menses. It's good. That means you're still young. You know, so it's good to have the menses and not to have early menses. It's good to have it as long as you can. Dr. Dimitri, you're around. Do you want to answer the other question?
Yes, that's really an
Yes.
incredible case. I'm just, I think that that is also should be properly analyzed, yeah, because, you know, it's a double-edged sword, you know, the menstruation past 55 years is a plus point to the increased risk of the breast cancer, you know, so we need to look at the hormonal profile and need just to clarify this case. But anyway, it's really incredible results, you know, so kudos, thumbs up for the doctor who has achieved such a tremendous outcomes. As for the gout, yeah, I mean, it's a complex problem that, as we all know, involves the I believe Dr. Wolha perhaps would recommend something best for the gouty arthritis as an internal medicine professor.
Yes, and Dmitry, Dr. Dmitry, and regarding the treatment of gout arthritis, we need to understand there are two reasons for gout generally. Can be the excessive amount of uric acid production or decrease the excretion of uric acid. That is why in second type, if for example we have some kidney disorders, I mentioned already in my lecture that the problem kidney causes the many other problems like the secondary calcification of arteries, the declining of clotting, violation of vitamin D metabolism, and many other, as well as increasing the risk for high level of hyperuricemia, so it leads to the gout. That is why, first of all, we need to understand what kind of type of gout reason for gout of these clients. In case if we know that it's a kidney disorders, if we talk about our product and by regenerative approaches, of course, we have the special our brand like Swiss Nature Kidney Health, which can improve the excretion, improving the excretion uric acid crystals and decrease amount of uric acid and urine. But also we need to mention that in gout arthritis it is essential the diet. So we need to exclude all products which can increase the production of uric acid. For example, it's seafood, is
Beans.
beans and meat, fish.
Red meat, yeah.
So it's a common question and cannot answer without any specify some reason for this.
Anyways, the treatment is usually holistic, so it will target multiple metabolic pathways. So maybe the LP-PSA, MKE, you know, this kind of things can be used in a combination. Yeah, but this is a multimodal approach.
Yeah, but if, for example, thank you, Dr. Dmitry. If, for example, this patient come to me and I pass through all results and history of this disease, I mentioned already that we need to check the kidney function. We need to understand what is the lifestyle, for example, because beer or strong alcohol can cause and can worsen the duration of this disease, of course. If we exclude and avoid these harmful habits and we still high level of uric acid, I will recommend conventional medicine treatment, of course. Another case, if we talk about the cartilage affection, so in this point, I think will be very useful our products like MO cartilage, so MO peptides, as well as the stem cells peptides. We also have the cartilage. That is why it can be like holistic approaches. We need to exclude all the factor risk and can replace the damaged cartilage. If I can answer for this question, or maybe someone can
Yeah, plus the systemic anti-inflammatory therapy, such as the placental peptides, as well as the Swiss natural IRS, is a very nice and interesting formulation that is targeting systemic inflammation. So it's, again, not a single modality. It's most likely will be a multi-dimensional approach.
The cartilage is with the synovium, which is also a missing link because you don't have the synovium after that. So you need the cushion, otherwise it will be erosion of the cartilage with the friction.
Mostly the anti-inflammatory, the placental peptides, NLP placenta, MO placenta, Swiss natural IRS, that's targeting the systemic inflammatory responses, you know, and that, of course, that will require a minimum, I would have say, not less than about 15, 16 weeks of continuous therapy before the first results are evaluated. Overall, regenerative medicine and peptide therapy, quite often we're asked the question, what is the time for how long we should continue this treatment? Well, when it's coming to the peptide treatment, it's what is the minimal duration of the treatment protocol required. This would be a more correct way of discussing this topic. So it has the cumulative effect. So prolonged duration is definitely brings more benefits rather than short-term treatment. So we usually recommend, if you're treating with the peptide therapy, it's nowhere less than 3-4 months and above.
Yeah, and I also would like to mention that some medicine can cause the high level, increasing the level of uric acid. For example, aspirin treatment. So many patients during the treatment of aspirin after stroke, after myocardial infarction, or some ischemic heart disease have experience about the high level of uric acid. What I can recommend in this case, so switch to another antiplatelet medicine, for example, clopidogrel. Other medicines like diuretics, for example, if we go through the top, so it's thiazide diuretic, so if we use the thiazide diuretic, we also expect the high level of uric acid. Then next will be lupus diuretic, furosemide, torsemide, and other. And minimum, it's veraspirone and like spironolactone. That is why the answer for this question precisely can be only after full understanding the case of this gout arthritis, because altogether can worsen the condition. And for example, if we will even recommend some conventional medicine, but when we, during follow-up, asking about the beer, so, and our clients talk that he cannot quit this, the harmful habits, how we can manage this problem. So it's really should be very, very precisely about the special case.
So in all cases, we need the physician to pass us the medical questionnaire, which the patient only needs 5 minutes to fill up. They can fill up with a pen or whatever, it doesn't matter, okay? Because we need to know a bit of the history of the patient and the siblings. It could be siblings with cancer, so we'll be extra careful, or diabetes. So the next one is the lab work. The lab work is good to have the last 3 months, okay? And we will send you a sample of the lab work because we have a standard way of where we need everything. Because a lot of times when we receive from US, a lot of the lab work are missing. Sometimes the tumor marker is missing. So I rather say we will send you something, you just go along with that, so that the patient don't have to do it a 2-time scenario where you have to do again another lab test. So once we have the lab work and the lab test, we can reply within 48 hours. Within 48 hours, we will give you the protocols. And you as a treating physician, you decide whether to take it up or you want to add to your other remedies. It's up to you because you are responsible for your own physician. We are just giving you a recommendation of what we have here, which we learned through our years of experience and with a team of good doctors, because we also have doctors in other parts of the world who are part of the team. So when we have certain things we are not clear on our side, but then we have to seek the opinion of our other colleagues in other branches you know. So that's the good part about us. And again, the alliance with many thousands of doctors around the world. We know almost everyone in this field, you know, because we have been, it's almost the same people in every part of the world. You go for A4M, you see a group of people there. You go for AMWC, Monaco, you see the other group of people. It's always the same scenario. It's either aesthetic or wellness. But these days, aesthetic also, wellness is there, and anti-aging sometimes is more aesthetic than anti-aging, okay? So it's mixed up, yeah. Any other questions?
This may be a follow-up to his previous question about the synthetic peptides. Which of your products would stimulate growth hormone production, kind of like Tesmorelin, CJC, or Ipamorel would do?
Okay, who want to answer this question? Dr. D, you're expert with growth hormones. Your lecture is tomorrow. You can answer some question here. Yeah.
If you are just interested in growth hormone therapy, then we have the Ultra AGH. It's one of the purest forms of the growth hormone, and we have been using that for quite a number of years. You can perhaps add on the pituitary cell extracts to enhance the endogenous production. For which purpose exactly, if you can specify, please? For the purpose of weight loss or?
For weight loss, but also dealing with people with muscle atrophy, mostly post-orthopedic injuries.
Well, of course, nothing can beat the growth hormone replacement therapy itself, you know. That's the golden standard, because everything else is not optimal, you know. For instance, the GRP6 can increase the production way more than the growth hormone or any other secretagogue, 8 to 6 times, you know, but it's going to be a very short acting, as you know, about 1.5, 2 hours, 3 hours maximum, and then it will work through the ghrelin receptors. You know, it's not many people can tolerate that, you know, that acute sharp sense of hunger, you know, that comes along with it. I personally enjoy it. I was doing GHRP6 for quite a number of months, and then perhaps even years, cumulative years, in a fasted state. And I was doing it early in the morning, fasted, and then I was doing fasted cardio, you know, and it really, really works, you know, fantastically. But otherwise, I like growth hormone replacement therapy. It's a king, of course, yeah. And when you do that correctly, and those physicians who are experienced with that, you know, that perhaps by far, arguably, it's one of the safest forms of the hormone replacement therapy ever existing. You know, so you can supplement that. You can add on, life hacks, what you can add on. Pituitary cell extracts, you know, just further stimulate hypothalamus pituitary axis, one. Secondly, GABA on night, and zero carb, high protein, or the pure protein, like the whey protein, right before bedtime, together with growth hormone or Ultra AGH, GABA, and pituitary cell extracts. That will be the, you cannot climb higher than that. It will take you to the peak of the Everest, you know, it's a stratosphere after that, you know. You can't stimulate it further. It's impossible.
Any more questions? Yes. That's
Actually,
two more. Yeah.
I would like to ask, just now regarding we're talking about gout, how about in a situation of osteoarthritis of a knee or osteoarthritis of a hip? The mitral organelles or NOP are going to help in this case, especially like for knee osteoarthritis, because I believe there are groups of patients that they don't want to go through total knee replacement. I've been wondering how this product will help. We have to exclude the patient that do not have any metabolic disease. It's just purely joint degeneration.
Sir, I believe that specifically this topic, I've recorded and prepared lecture on the minimally invasive treatment techniques, and mostly that lecture is emphasizing on the osteoarthritis, and it's all in the book, minimally invasive techniques in daily practice of anti-aging regenerative medicine physician that we have released last year. So the injection points and the protocols are pretty well described there, and I've included even specific cases, like what we use, what will be the cocktail and a combination on the protocol on the first session, second session, what is the duration in between, and correct me if I'm wrong, Dr. Bhavani, but I think the lecture is to come during this seminar.
Yes, it will be aired propagatively from day 3 to day 4. We have both the HTH as well as the non-invasive pain management.
Yes. And in that lecture, I've put what are the actual protocols and what is the actual, what are the ingredients of the cocktails that I use on every session, including starting with the local anesthesia, the potentiated local anesthesia, what products are injected articular and periarticular, plus the perineural infiltration. Everything is there. But answering your, just moving forward a bit, and then just jumping in day after tomorrow topic, yes, definitely we use especially the NOPs, the nanopeptides, because the bioavailability is fantastic and they're very safe and they do not give any local reactions and are very well tolerated when they administered in soft tissues around the joint and all. And we do combine intraarticular, periarticular administration, plus we use cellular and decellularized products, exosomes, and the combination of NOPs together with different peptides, even the growth hormone, which, by the way, is very safe to be injected intraarticularly because, and it also helps directly to target the cartilage cells by increasing their mitotic activity. So you can not just reduce the inflammatory reaction in the joint, but you can also stimulate the cartilage regeneration after that.
We will do some demo on the third day. On the third day, we will try to do some demo after Dr. D lectures. We have time on the third day and fourth day. Dr. Simon can do something there, or Dr. Glenn can do something to show some of you, because a number of you are asking about the knees, So this is our usual affair when we treat a patient. You have a knee pain, you have a shoulder pain. These are something we do it all the time. Okay, it's the same for the hip. Yeah.
I don't mind being one of the experimentee for the knee injections. Yeah. Okay. So
okay,
I'm very,
you are selected.
Thank you. So okay, I have both my ACL torn, so I have some OA. So anyway, one of it was coming down Kinabalu mountain. I popped it. There was a literal sample. So I'm very interested in reversing hemodialysis patients, or at least save them from hemodialysis for CKD patients. So I saw part of your lecture showing that one of the great men has completely stopped dialysis, and then some other patients, maybe they have reduced to 2 times, something like that. So can you maybe highlight something about that, and how many treatments do they go for, like for example, for complete cessation of the hemodialysis? Thank you.
No, we cannot say we can stop
It's important to understand that for the CKD, the success will depend on how early you start the treatment. If the chances in end-stage renal failure are slim, and of course they are less than 1%, they're perhaps 0.000 something 1%, potentially can be reversed. With the stage 4, yeah, perhaps you can delay the onset of the end-stage renal failure. The statistics is slightly better with the 3B and 3A stage. You perhaps can downstage in about 40 to 60% up to a year. But here also very important to understand the cause of the, first of all, if it's a young patient, the chances are worse. If it's the autoimmune nephropathy, the chances, of course, drop dramatically. So diabetic nephropathy, all the patients respond well. Focal segmental glomerulosclerosis perhaps can respond well, provided that lifelong therapy is implied and the blood pressure is controlled and all. And it's not just about reversing the kidney function, but need to look at the actual pathways, what have caused that, and address that first of all, because the kidney failure is just a tip of the iceberg, and I need to treat the actual condition that have caused that. If we recall the case of Mr. Michael McGuinness, well, there was a bilateral renal artery thrombosis, and there was a radiological study done with isotopes in University Clinic in Los Angeles, and they've managed to see the traces of the labeled substance in the kidney tissue, and that gave a hope. So first of all, it was like 2 months of anticoagulants and peptide therapy and trying to recannulate the thrombus, sorry, not recannulate, to revascularize the kidney, the actual renal artery, And he responded well. Well, he was lucky to respond well to that therapy so that stem cells and peptides could actually reach kidney function, So that's why he was, it was a promising case, from the very beginning, and that's why I managed to reverse it. Unfortunately, not in every case, but we wish that it can be done, and we're trying, to improve our treatment protocols and all. One of the recent cases managed to reduce the frequency of the regular hemodialysis from regular 135 to just twice a week, or the PRN. Well, that's of course because it's a great relief also for the patient and the family as well, So yeah, I hope I answered the question. But again, in every case, we need to look at the case and analyze that and look at what has caused the kidney function. And the earlier, the better. The earlier the stage, the more chances of downstaging.
It's actually interesting because I have a case of a chronic kidney disease with a baseline creatinine 1.6. And functional medicine, I checked for toxins, and it was high in mercury, lead, and there were other environmental toxins. So when we did chelation, it actually improved by up to 1.2, but it stopped there. So I'm hoping maybe with your product, maybe we can improve his kidney function more.
Yeah, but you do understand that when you detected the high levels of mercury and all, that is the consequence of the CKD. It's not the cause of the CKD. So you need to look what have caused that. And as I have said, autoimmune, unfortunately, do not respond well as we wanted to respond. And the young patients, the younger patient, the worse will be the prognosis.
Yeah, but my question is, I have an interstitial lung disease right now, and I just started. She just started seeing me. She just uses oxygen as needed, so she's not on 24/7 oxygen yet. So,
yeah,
I just started using exosome nebulization for her.
Yes, lovely. And use it together IV and with the mitochondrial peptides. And I believe that a few years ago we had a very interesting case of interstitial pneumonia that we have treated in Portugal. It was our Dr. Rony Moya, who is based in Portugal. He was the main treating physician. He used lung frozen cells from the lung tissue together with thymus. And the patient was actually recovered. The patient was eventually, after 2 sessions of cell therapy and immunotherapy, was discharged from the follow-up and doing quite well. And it was such a remarkable case that we have published it. It's available, the publication is available on our website. It's about the case of the interstitial pneumonia. So the entire treatment protocol, what products and what types of we use frozen cells, FOCs for that, and thymic peptides and SI, if I'm not mistaken. You know, I don't remember the sequence. You know, it took more than a year, sir, to treat that patient, but almost 2 years, you know, but really incredible results. And I would say practically a complete recovery.
We use the stem cells, the precursor cells, I would say the result is even better. But because sometimes the patient can't afford certain things, so there was compromisation. So the expectation of all the patients is always very high. They always say, I paid you the money, I must get the results. But sometimes you also have to explain very carefully to what level this can do and the other one, what level it can do, you know. So it's important to go with that. The peptides is always a support therapy. But when the patient don't have money, then the main therapy is not out, is out, then you have to use the support therapy as the main therapy, you know. Yes. Yeah.
Thank you very much. I hope that addresses. Yes, we will continue taking questions. I will just read out one that just popped up in Zoom now. If a patient received progenitor stem cells already and it was said to recommend the patient to continue NOP, which route of administration will be better for the patient, IM or sublingual?
I believe that would depend on the patient, preference of the patient, and whether the patient is capable or has the setting and the setup for injection, whether the patient is willing to do the injection. But as Dr. Mike has mentioned earlier, with the NOPs, you know, it's a dual route of administration, can be used as injectable, can be used as sublingual. Then it will also practically, of course, will be slightly less bioavailability. Something will be swallowed, you know, but it's an alternative route. And perhaps to increase the bioavailability with the sublingual route of administration, we'll have to increase the frequency. So usually we do injections 2 to 3 times per week. And perhaps if it's a sublingual route, then perhaps daily or every other day. You know, that will be the way to keep that, compensate the bioavailability, you know, some percentage of loss if some product is swallowed. But if injection is not a problem, if it's convenient for the patient, if there are no contraindications, if there are no limitations, then that would be a golden standard.
So my question is about immune problems. So I was wondering, I know that you have your peptide timers, super transfer factors, there's a GC-MAF. So when do you choose which? And it's like most of the literature is around autoimmune diseases, cancer, how about acquired immune deficiency syndrome? So, you know, you see patients with HIV, you don't want to wait for them to get to the AIDS lane. And so which route do you go? Which one do you choose? Why do you choose one over the other?
Very good question. It's a lovely question. And to answer that question, first of all, I would suggest that you need to read the book, Immunotherapy in Bioregenerative Medicine. Actually, if you read that book, perhaps you will not ask this question anymore, because immunodeficiencies, both primary and secondary, are a separate chapter in the immunotherapy book that has been published and released about 2 years ago. So the explanation and the protocols and all explicitly have been given there. Mostly, we would have emphasized on a thymic therapy, on a thymus therapy, in different forms of the thymus therapy. How exactly it's done and all is described in that book, as well as we have published last year a book on thymus therapy only, and that book has all information what mankind as a civilization to this date has generated regarding the thymus therapy. All the experience, all the past publication, all clinical trials, all the forms of the thymus therapy that ever was used by the mankind are in details, with references, with citations, are described in that book. We're talking about a few hundred pages of explanation of how the thymus therapy, of what mankind has done about it completely. There's nothing else to read apart from what's written in that book. Okay. Continue and answer your question. We have different types of the immunotherapy products because the immune system has got different pathways, and each product will mostly target different pathways. If GCMF only targets monocytes, it only activates phagocytosis, nothing more, nothing less. As for the supertransfer factor, well, it depends. It depends on the protocol and duration of use. If you use a short term, like 1 week, 2 weeks of transfer factors, well, mostly you will stimulate NK cells, innate immune system. And that is used in cases of some viral infections, and perhaps also can add it on to the treatment of some forms of cancer, or when patient is on other forms of immunotherapy, or maybe chemotherapy, radiotherapy, to further enhance effects of the adjuvant therapy and reduce the side effects. We add on thymic therapy and thymus peptides, or even the progenitor, thymus progenitor stem cells, plus the transfer factor. When you use transfer factors for a long duration, 4 months, 5 months, 6 months, mostly that will target the imbalanced humoral and cellular immunity, and specifically the autoimmune condition. So it will sort of bring back the equilibrium between the humoral and cellular immunity by stimulating or upregulating the cellular component and slightly suppressing the humoral immunities, thus reducing the autoimmune component. ASI is, perhaps there was a lecture given, that is also mostly for the autoimmune conditions, allergic conditions, and also some forms of prevention. It will add on towards the preventing the recurrence of some forms of solid cancer. So depending on the actual case presentation, then we will choose which pathways we're going to target. But quite often we use a combination of them all because the patients present with multiple problems, so just to target all pathways of immune system, we use a different products in combination.
One more very straightforward question. Do
Yes,
you
please.
get better prognosis with type 1 or type 2 DM? I'm talking main therapy, stem cell.
Wow. Interestingly, I was just discussing this topic with two very prominent transplant surgeons, who are just day before yesterday, who are actually involved in treatment of diabetes type 1 with pancreatic transplant. So answering your question, at this point where we stand, definitely diabetes type 2, because the reversal of the diabetes type 1 is rather an anecdotal, episodical cases that none of them has lasting effects, put it this way. Definitely type 2. But we need to understand in the same time that diabetes type 2 and diabetes type 1 is totally different diseases, and the only commonality between these two things is the word diabetes and the word type. And the commonalities end here. So basically we're comparing two absolutely different diseases that, because of the lack of understanding of how this condition develops in the past, it was given a misnomer. Perhaps in the future we'll stop even, there's no diabetes type 1 and type 2, there's a There's a Sweden classification been given a few years ago. It's 4 types of diabetes. It's not even at this level of discussion. I don't think that it's even reasonable to label and tag these conditions as diabetes type 1 and type 2 because we are not in a first year medical school anymore, so we're discussing something more advanced, so definitely diabetes type 2.
I totally agree with Dr. D. Type 2 is easy, and you give the stem cells on the islets and again with other organs affected by the condition. But in type 1, it's autoimmune. So our type 1 means it's not just the islet cells. The autoimmune route is not soft. So you have to put the autoimmune route under control. So in our experience, been doing it in the AASI, but it's a lifelong monitoring, It has to put it under control all the time because it's autoimmune. There's no cure for autoimmune, but you have to solve the root by keeping it under control. So that means ASI is needed there all the time, Yeah.
By the way, Dr. Sri, do you remember our case? So our clinic has experienced that 32 years boy with first type diabetes mellitus after treatment, after one course of ASI, sent us the feedback that from 40 units insulin, he decreased amount up to 20 units. So we already received the feedback that's also good results. So it was the stem cells, live precursor stem cells, as well as the peptides, LPCMK and ASI. So these 3 options, and we receive, I think, after 2 months treatment, it's quite good results.
It's a true case. So like she says, it's autoimmune, so she use ASI, but at the same time to repair the organ damage, we use the islet cells of the Langerhans, from the pancreas, the stem cells. But at the same time, we keep in control together with the contouring repair with the LPPSIMK, pancreas, placenta, stomach, intestinal mucosa, kidney, and the eye, for the metabolic.
Well, that's all anecdotal cases, but if we want to look at the statistics, during the pandemic, we have done experimental work, and it's a work on mice. It was done in University of California, Irvine. Professor Jonathan Leakey was the head of that group that conducted experiment. Experiment was done in a span of 17 weeks. It was a classical model of the induced autoimmune diabetes type 1 in mice. It was a controlled study. It was controlled with placebo, normal saline, and the main group received MO pancreas injections twice a week at the human dose, which was scaled down to the body weight of the mice. And starting from the second week, the main group showed better glycemic control compared to the control group. And by the end of the experiment, the cohort of the non-diabetic mice was 33% higher in the group that was treated by pancreas cell extracts compared to the normal saline group. That is the actual verified statistical data that can be presented. They've also run some of the cytokines assay at the same time. And what they've noticed is that in the mice that did not develop diabetes and responded well to MO pancreas, the assay of the erythropoietin was 90% higher than in the mice who have developed diabetes. And the interesting fact is that the EPO plays a very important role during the fetal development of the islets of pancreas. It actually is one of the essential cytokines that will help to help the islet cells to maturate and acquire the functional potential. So one of the conclusions from that study was that perhaps one of the pathways through which diabetes did not develop was actually through the stimulation of the EPO. But perhaps I believe that it's a wonderful data. It's a very, very interesting data, and we have agreed with University of California, Irvine, that they will continue this, further elaborate this study, because we'd like to see. It shows a great potential. 33% non-diabetic mice. It's tremendous result. So now we need to figure out how to extrapolate that to humans.
Naltrexone for immune regulation, because I've been using thymosin alpha-1, TB4 frag, and low-dose naltrexone for autoimmune. Maybe it's a good combination with the SSI.
Perhaps. Why not? Why not? Absolutely. Great idea, Doc.
I have a question. As a recent days, we know a lot of report about the side effect of the COVID vaccine. Do we have the product to treat this problem?
Yes, and we have developed 3 types of peptide solutions for COVID cases. One is for acute COVID, one is early as a recovery, and one specifically to target the late consequences of both unwanted adverse reactions or responses to vaccination as well as the COVID. All these 3 types of peptides have it's a combination. There's 3-4 different types of peptides. They're all different. We have tried it. Mostly we have tried it in the United States, and we have so far wonderful feedback. The doctors who have been using that in the American Academy of Stem Cell Physicians, with good results for quite a number of years, to the date. And yeah, definitely. It's available. It's available, and I believe that we didn't include it specifically in the seminar, but if you talk to the technical and support staff there, on the ground, they will direct you to the exact product that I'm talking about. But it's a big problem, really, indeed, sir. The myocarditis and and apart from the myocarditis, that long-lasting problems with the cognitive function, the poor memory and all that, patients keep on complaining for months and years, after the COVID as well as after the vaccination. And it's not a hoax. It's something very, very obvious, and we see that it's very obvious. It's very obvious for patients. They clearly see the consequence. They can link these symptoms, memory loss, and sort of like a foggy brain, to the event, to the episode of a COVID.
All right. Thank you, everyone.
Thank you.
Okay. I know you're tired.
you.
You come from very far. Some of you come from USA. Some of you came from Japan and Australia.
Thank you very much
yes.
to all the delegates and the speakers for the patient Q&A. We would like to call upon for a group photo for today, because tomorrow we have a different segment, which is CPD. So speakers, please go forward towards the stage.